So my name is Daniel Dees. I'm a movement disorders neurologist at University of South Alabama in Mobile, Alabama. I'm very thankful for the opportunity to get up and come talk to you guys. And the first thing that I would say is this is absolutely not a lecture. Like, we're just hanging out, talking about brain. So as we're going through, and if you got questions, or hey, what about this thing, or I don't know, this thing over here, like, go for it. Like, we're just having a good time. And some disclosures: these are companies that I work with. I do consulting for them. And I have a grant through Huntington's Disease Society of America by way of UAB. That's a patient care grant. So we use those funds for patient care type things and stuff like that. So I always like to start with historical perspectives on things and kind of defining what things are in Huntington's disease and stuff like that, so we're all on this kind of same page with it. Huntington's first described on paper, although Huntington's has been around for a long, long time, right? Probably the longest humans have been around. By George Huntington, first described it in 1872. And he wrote about it. It was a case series, just a small number of patients. Nobody really thought much about it, didn't make a big impact. And after that, people thought it was going to be a pretty rare thing until later on, in like 60s, 70s, where we realized, 1960s, 1970s, we realized this was actually a really common thing, so not so rare after all. So Huntington's disease is a CAG repeat problem, so this is a genetic problem. And so at the end of, on your chromosomes, there can be these like long trinucleotide repeats. So in other words, these repeats of little three-section units of gene. They can kind of say, hey, we're at the stop end of this gene, or it can mean different things. And where you get into with Huntington's disease is it's a CAG repeat problem where you've just got too many of these repeats all in a row. And so, there's nothing hard and fast about the numbers that we throw around, but just for the most part, we say that if you have less than 32 CAG repeats, then you're not going to get Huntington's disease. If you have more than 36 CAG repeats, then you're probably going to get Huntington's disease. The higher the number of CAG repeats that you have, the earlier onset you're going to get. So in other words, if you have like a pretty small number of CAG repeats, we'll say like 39 CAG repeats or something like that, you can have onset of Huntington's disease way later in life. So you can have onset of the movements and all that with Huntington's, maybe in your 80s, like that can happen. If you have a really big number, say if you have like 60 CAG repeats, you're going to have onset much earlier in life. So you can have childhood onset of Huntington's disease is a very real thing. So that number does matter. And to an extent, there's always variability, from one individual to the next. But, the big picture type stuff, the higher the number of CAG repeats, probably the earlier onset you're going to have. And there can be a little bit of variability even there too. So what's really interesting is that CAG segment of the gene is really stable when you get it from mom. So in other words, if mom has 42 CAG repeats, it could go up or down by like plus or minus 2. So in other words, if mom has 42 CAG repeats, maybe you're going to get 40, maybe you're going to get 44. So it's just a minor change there, and the difference between 40. CAG repeat wasn't stable in the sperm there. So dad had 42, you got 49 CAG repeats, and maybe you're going to have onset of Huntington's a little bit earlier in life because of that. It can go the opposite way too. If dad had 42 CAG repeats, well, maybe you get 35 CAG repeats, right, which is quite a bit lower. And, we said there was kind of a gray area there between 32 and 36 of maybe you're going to get Huntington's disease, maybe you're not going to get Huntington's disease. I don't know. It depends on how long you live, that type of thing. So maybe dad had 42 CAG repeats. You got 35. You got the gene. Like, it's the same gene that dad had. You got it. But you only had 35 CAG repeats. And so now you're in that gray area of maybe I'm going to get this, maybe I'm not, which is really fascinating. You can't say that about most genetic disorders. So, most genetic things, we'll say, because Huntington's disease is autosomal dominant, which means that if mom has this, each of mom's children's individually, you'll have a 50% chance, you'll have a 50% chance, you'll have a 50% chance, which is a little bit different than like, some people say, well, I got an older brother, my mom had Huntington's, my older brother has Huntington's, that means I'm not going to get it, right? And that's not how this works. It means that brother had a 50% chance, okay, and then you have a 50% chance, okay, all right? So it's a little bit of a different type of thing. But, that kind of variability of these CAG repeats can sometimes play a role. Average age of onset for Huntington's is going to be age 40, but there's huge variability there, right? You can have onset as a 4-year-old, you can have onset as an 84-year-old, so there can be a lot of variation there too, mostly depending on the number of CAG repeats you have. And then once you start showing the movements of Huntington's disease, and things will typically play out, everybody's a little bit different, but typically play out over maybe 15 or 20 years or so. And Huntington's is pretty common. I'm a very much an optimistic person. I love this quote. This is Ram Dass. I'm not this body. I'm in this body, and this is a part of my incarnation, and I honor it. But it isn't who I am. Right? The body's just like the car you drive around in. Who you are as a person is up here in your mind, right? And it's defined by the actions that you've done and the decisions that you've had and these sorts of things. It's a wonderful quote. So we'll kind of just briefly hit on the different stages of Parkinson's because I think people can get interested in that. We can kind of subdivide Parkinson's into 3 different stages of early, middle, and late. I'm sorry, I said Parkinson's. We can kind of define Huntington's disease as early, middle, and late onset of Huntington's disease. So early Huntington's disease, individuals are, for the most part, they're just out living life. They're pretty independent. They can go do stuff. They can work, drive. They can handle their finances, live independently, all those types of things. And maybe they'll get a little bit of hyperkinetic movement, too much movements, and we're going to look at what some of those look like. And maybe a little bit of loss of coordination, and maybe a little bit of problems like thinking through math problems or doing puzzles or that sort of thing. But for the most part, it's not a big role. Kind of middle Huntington's disease. You start defining this by folks are starting to have the problem of like getting to work, driving around, being independent. Running their own finances, paying the bills on time, all that type of stuff, and then getting hair and makeup, cufflinks, stuff like that, ties, tying the shoes, these sorts of things start to become a little bit more difficult. Maybe you need a little bit of help with them. And then you can also get into things like starting to get into problems like swallowing foods and liquids and stuff like this, and maybe a little bit more of executive functioning problems. So things that like problem-solving skills, how you go put the puzzle together, stuff like that, 3-dimensional, visual, spatial type things. Kind of an example of that would be getting into minor fender benders in the parking lot would be a good one of visual spatial problems that Huntington's patients can get into. So, driving down, down the 4-lane road, not so much of a problem, but the visual spatial problems of, oh, I didn't see the car there, and, just a little fender bender or something like that can start showing up. And then later Huntington's disease, they're going to need some help with activities of daily living. You're still there as a person, right? Like you're there as a human, and you can't get your body to move in the ways that you want to go move and do those sorts of things, but you're still there with it. And the chorea can be pretty wicked, although as you go through Huntington's disease, what's fascinating is it starts out as too much movement and too little movement, both at the same time. But then as you're going through it, it becomes much more of a just not enough movement problem. So too little movement of a problem. And the part of the brain that is doing the too much movement, you kind of lose that over time. So then it just becomes too little movement. And then you can get into some of the things like depression, stress, anxiety, like some of the psychiatry stuff that we're going to talk a little bit more about today, this time. So the movements that you get, we're going to go through and define all these movements. You get things like chorea, which I can say is involuntary movement flowing in X, Y, and Z planes of axis from one joint to the next. These small, slow movements and muscle stiffness and rigidity. You can get off balance and falling down, and then these quick little muscle jerks here too. So chorea, this is most patients with Huntington's disease will get this stuff. So with chorea, it's an involuntary movement flowing in X, Y, and Z planes of action from one joint to the next. So it's flowing from like my fingertips and the wrist and the shoulder and then back into the fingertips. This type of thing is going to be chorea. All right, and it can be a little small, slow stuff. Like if it was slower, we would call it like slower and smaller, something like this. We would call that athetosis. It's all the same thing. Or if it was big and fast, sometimes you hear the word ballism. It's all the same stuff. This is all just chorea, these flowing movements in the hand. And it's not just in the hand, but it's everywhere you got. So it's in the hands, in the feet, in the trunk, the lips, the tongue, the everything, right? So you get all this as chorea. And this can get in the way of daily living. This is subtle chorea, right? So this kind of involuntary movement going on in the hands. And most likely, like with this type of smaller movements, you're not going to notice you're doing it, right? You know, you're just off paying attention to whatever's over here, and you know, I don't know, the movie theater, the church service or something, and you don't realize that you're doing this with the hand, and you are. So a lot of times what will happen is the spouse will notice it first, or the friends, the family members, or whatever, and they'll mention it, but a lot of times the patient doesn't recognize that they're having this sort of a movement. So that's kind of earlier chorea. And chorea can create some real problems, right? So it's not just in the hands, but it's everywhere you got. So it's in the legs and the toes and the trunk and these sorts of things, and it can knock you off balance. So, you know, like if I'm just standing here and I start, you know, moving around all over like this, I really have to work to not fall over. The first thing I did was I put my feet kind of wider, right, to give myself a wider base to be able to handle that so that I don't start falling down when I'm creating all of this momentum as I'm moving around. But in Huntington's, if you've got some loss of an internal sense of balance, so you're a little bit more likely to fall. The classic descriptions, before I realized I was falling down, it's too late for me to do anything about it. Like if you've got that internal sense of loss of balance, and then you've got the momentum that you're creating all over the place, it's pretty easy to knock yourself over to the side. And then to be able to go fix that, I got to go make a big step with my foot, just like what I did. You know, I'm kind of all over the place, and boom, right there, and then I caught myself. But that's a big, fast movement that I got to go make. And one of the problems you get in with Huntington's is it's not just all these extra movements, but the movements get too small and too slow too. And so it can be difficult to make that big, fast movement with my leg to be able to go catch myself so I get my center of gravity back in between my 2 feet. Right? So this is an example of some pretty bad chorea. Right? She's really all over the place. And it's creating a problem in a moment here. She's going to stand up, and you'll see her kind of get off balance a little bit, and she's got to catch herself. Now, the good thing is there's a lot of medicines we can do with chorea. So there's a lot of things that we can make this better. But right there, she has to kind of catch herself right there. And kind of interestingly, this was HDSA, survey of patients in 2016, 40% of patients said they felt like they were either unaware of chorea or they weren't taking medicines to go treat chorea. And you've got some options there from a medicine standpoint to deal with these hyperkinetic, the too much movements of like things like chorea. So you get the medicines like they get called as antipsychotics, as they all came out in the late 50s, early 60s, but we use them for lots of other stuff than things like bipolar schizophrenia. So these are medicines that work by blocking dopamine. So the older medicines would be things like Pimozide, ORAP, Thorazine, Haldol, those sorts of things are kind of older medicines. They can create problems in that they make people really sleepy and this sort of stuff, but they can help slow down the movements. And then you've got a newer class of these types of medicines that came out in the 1990s. They get called the atypical antipsychotics, or sometimes they call them the second generation antipsychotics. And those would be medicines like Respiratory, Seroquel, Zyprexa, Geodon, Clozaril, Abilify, those types of things that are much more commonly used now. They don't create as many problems as some of the older medicines do, although they can still make you sleepy. And they work by blocking dopamine. Dopamine's the neurotransmitter of movement. So an example of what happens when you don't have enough dopamine, like Parkinson's disease would be an example of if there's not enough dopamine, where all the movements really slow down and get small and stuff like this. So with these sort of dopamine blocking medicines, well, they're going to make the movements smaller and slower, right? And so then that can be really helpful in Huntington's, where you've got too much movement and everything's kind of flowing. But then also, if you're taking too much of those medicines, it can slow down the movements too much. And then the movements get all too small and slow. So I always like thinking in terms of things that can make the movements worse for today, like right now today. So all these extra movements like chorea and stuff like this is going to be worse if you get stressed out, frustrated, anxious, excited, too much caffeine, not enough sleep last night, morning after alcohol, great news. You just won the lottery, you know, and then you're going to have all these extra movements because you're excited. Or terrible news. Your friend's in the hospital, you know, and then you're going to have too much movements because you're worried about your friend. So it's important to understand that with all these extra movements, things like that are going to play a big role in it, right? So that you can have really bad movements today. Everybody has good days and bad days, right? You can have really bad movements today, but maybe it's because, you know, you're really stressed out, or you're really frustrated or angry, or you're really excited, or caffeine, or any of these types of things. Like, all play a big role. Okay, we were talking about movements that are too small and too slow. So bradykinesia is the fancy word for not enough movement. The movements are too small or slow. So I had to be able to make this big, fast movement like this, right? And in Huntington's, you get too small of movements too. So the whole thing can be too slow, or it can be that it starts out big, and then as I keep going, it gets smaller and smaller and smaller. Or it can be that I'm going and I'm doing okay, and then it gets stuck, and then I start going again. So it's all three of those things are too small and too slow of movements in Huntington's disease. So this is going to get in the way of activities of daily living, right? The same things we were talking about. So, you know, hair, makeup, buttons, this type of stuff, tying the shoes, walking out to the mailbox, these types of things. The bradykinesia, that's too small and too slow movements can be a problem. So this patient doesn't have Huntington's disease, but she's a good example of what bradykinesia looks like. So I want to show you what the movement looks like.
Go ahead. Big and wide and as fast as you can do it.
So you see how slow this movement is here? She ought to be able to make these big, fast movements with her fingertips.
Big and wide and fast.
And then she's got small, slow movements of the face, too. So you don't see a lot of facial expressions.
Big and wide and fast. Fast, fast, fast. Okay, start. Go as fast as you can. And switch hands.
Okay, so these are the small, slow movements that you would see in Huntington's disease. And like we said, with medicines like Risperdal, Zyprexa, Seroquel, these sorts of things, we use those for all the extra movements, the too much movements, the chorea. But then because they're slowing down the movements, if you're on too much of those medicines, then sometimes they can make the movements too small and too slow. So they can make the things like the bradykinesia a little bit worse. So then it's a balancing game, right? And you know, the first thing that I would tell a patient, we're going to start a medicine for Huntington's for the extra movements, is say, my goal here isn't to make all of your movements perfect and normal. I can't do that. But what I'm trying to do is to make these extra movements so that they don't bother you, so that they're not a problem in your daily life. That's what I'm trying to achieve. And other things with things like bradykinesia or not enough movement that can be really helpful would be things like physical therapy. Like, never underestimate what you can get out of physical therapy, occupational therapy, speech therapy. Like, these things are huge. And there's great resources on the HDSA website. So go check out that website as far as physical therapy, occupational therapy, speech therapy. So another one of the movements you'll get in Huntington's disease is dystonia. And I can define dystonia as a sustained involuntary contraction, and this is something that everybody in the room has had before. So a good example of dystonia that everybody gets is that little twitch in the corner of your eye when you're stressed out, frustrated, lack of sleep, and it's really annoying, and then you can kind of like rub it out and it goes away. That's actually a version of dystonia. Or like, I get dystonia in my hand, and it, like, the little finger will twitch back and forth all the time. That's a normal movement to an extent, but it can get to the point where it's a real problem. Or another example of dystonia that probably everybody has done before is, you know, your handwriting. So you're taking notes in class, and oh man, like, there's a lot going on here. I got to take all the notes, right? And then the hand kind of starts cramping up, and it's involuntary muscle contraction. And it starts kind of hurting, and I got to put down the pen and then do this thing, right? And then I can pick up the pen and start going again. Well, actually, that's a little bit of a version of dystonia. But in Huntington's disease, it's not going to be just with handwriting. It can be everywhere that you got. It can really affect things like walking and moving and these sorts of things. And how do you go treat things like dystonias? Well, they're a lot more difficult to treat than things like chorea. Because you can do things, well, if I say the muscle is just contracting too much, then I can do things like Botox or botulism toxin injections, which those work just by weakening the muscle. Like, they last for 3 months, and you got to do the injection again, and then that's it. And well, if you got like terrible dystonias in your hand, and I go inject your muscles of your hand, then it just becomes floppy, and you can't go use it. So then that creates a real problem, right? Because now I can't even pick up the pen in the first place. You know what I mean? You get medicines like Artane, which is trihexyphenidyl, or Cogentin, which is benzaprine. And they can help a little bit, but it takes like super high dosages, and most of the time people can't tolerate it so well because it causes dry eyes, dry mouth. In older patients, starting about age 60 or 65, start causing like confusion, hallucinations, stuff like that. So it can be a real problem trying to use those medicines. So things that will make it worse just for today, it's that same list of things. Like if you get stressed out, frustrated, anxious, upset, morning after, alcohol, caffeine, all those sorts of things are going to make it worse. And to an extent, you can't control that stuff. Like that's just a part of life. I mean, you cannot drink caffeine and you cannot drink alcohol and you can try to go to bed at a reasonable time. But stress and anxiety and frustration and stuff, that's just a part of life and that's okay. So let's understand how it's going to affect me today. And then the last movement that they get, and this is a little, it's not quite as, typically doesn't play as big of a role as the other ones, are myoclonic jerk, which are these are really quick involuntary muscle contractions lasting less than 100 milliseconds. They're so fast I can't even demonstrate them for you. A good example of myoclonic jerk would be as you're transitioning from awake to asleep and you kind of do that sort of thing. That's an example of myoclonic jerk. And to an extent, it's normal. Or another version of myoclonic jerk would be, it happens to me a couple times a month, but like you're sitting there watching television and just hanging out, I don't know, and then you get like that big thing right there, you know, like, but it's a real fast movement. To an extent, these things are normal. That's myoclonic jerk. But in Huntington's disease, you'll get a lot more of it. Okay, so that's kind of a quick overview of the movement problems in Huntington's disease. Now let's talk about the non-movement problems in Huntington's, because it's really easy to focus on this, right? Like here it is, it's in front of me. We can all see this, but maybe we can't all see the things like depression, stress, anxiety, and stuff like that that's going on like behind the window, you got me? That's a little bit less evident. And things like anxiety or irritation and taking it out on folks, frustration, the visual spatial things we were talking about with the little fender benders in the parking lot, those sorts of things can play a big role. There's a lot going on in this slide. And so we're just going to kind of break it down into little subheadings, okay? But this is looking at about 580 folks with Huntington's disease. And the red ones are the Huntington's disease. The light blue ones, they were comparing them to Parkinson's patients. And then the dark blue ones are just folks in the population. They don't have neurology problems. They don't have Parkinson's or Huntington's disease. They're just in the population that we're calling as normal. And so if you break those things down into depression, dementia, anxiety, stuff like that, those are going to play a huge role in a lot of patients. So depression in Huntington's disease is 40%, like 4 out of 10 folks are going to have depression there, versus in general population it's 15%. And depression can be absolutely crippling, right? And then things like dementia, so this would be cognitive problems of, you know, paying the bills on time, or problems doing, putting the meals together, like working out in the shop, in the garage, stuff like that. Those sorts of things can play a huge role. And then how do I deal with that? Now, Alzheimer's disease shows up here, and that's a little bit interesting. And I think it's important that it's a real small number. They put like 2% on here. But what that makes me think is having Alzheimer's disease and Huntington's disease are two completely different things, right? They are not related in any way, shape, or form from where did the disease come from. But Alzheimer's disease, you know, there's not a blood test that I can give you to diagnose Alzheimer's disease. Now, there is a genetic test we can do for Huntington's disease. But what it means is a lot of people can get diagnosed as dementia and then called Alzheimer's disease, but I can't go prove that with the blood test. And then, you know, maybe a little bit later we find out, oh no, wait, you know what, this is actually Huntington's disease. And we did the blood test, we did the genetic test. And so sometimes things can get a little bit mislabeled as we're first diagnosing them at the beginning of the disease state. Depression and anxiety plays a huge role, right? I think especially for us big dumb males, which is me, you know, we don't like to say that I'm depressed and anxious, right? It's more easy for me to just take it out as I get frustrated as those people around me, or I get really agitated easily, or sometimes, you know, he just gets angry at the flip of a switch and then we're yelling all of a sudden and stuff like that. Like that type of frustration for big dumb guys, sometimes that's how we kind of do the thing. That's how we take it out. And I think some component of things like depression can come from, again, speaking for the big dumb guys, like we put our sense of self-worth, our sense of value in our ability to go do the task, especially the type A guys that are a little bit OCD and ADD, which is totally me, right? And a lot of times you see those sort of personality traits with your engineers and your doctors and your lawyers and stuff like that, but they're all over the place. We put our sense of self-value in our ability to go do the task. And then when I can't go do the task, I lose my sense of self-value. And that's really devastating, right? And the ability to go do the task can be 1,000 different things. Maybe for some folks it's, I want to mow the yard. For some folks it's that I want to keep doing my day job. I want to keep working at the engineering firm. Or whatever, I like to do woodworking. So I want to be able to continue to make the furniture or something like that. And that's where I put my sense of self-value. So that can be really devastating. And then it's recognizing that, hey, you know what? It's okay to have depression. This is all right. Let's talk about it. Because one of the worst things you can do with having depression is ignore it, right? And so then let's talk about it with the spouse. Let's talk about it with the family members, with the kids, with wherever your social circles are, if it's at the church or the community or, I don't know, the arts council, like whatever you're into, like let's just go talk about, hey, this thing's going on, let's not ignore it. Anxiety is a little bit of a different animal than depression, but in some ways they're related a little bit. Like they tend to kind of go hand in hand, although they can be isolated. You can just have anxiety and not have depression, and you can just have depression and not have anxiety. But a lot of times they tend to go a little bit hand in hand. And the first thing I would tell a patient is, my role is I'm a neurologist and I'm a movement disorder expert, but I'm not the psychiatrist, and I can't know everything about everything. Let's go talk to the psychiatrist, right? They're the experts in this field. So, if you had a heart attack, you're going to go see the cardiologist. You're going to go see the heart doctor, right? Or if you got kidney problems and kidney failure, you're going to go see the nephrologist, the expert in kidney problems. So if you have things like depression and anxiety, let's go see the psychiatrist. But it's not just the psychiatrist, it's the psychologist too. Psychologists can make a huge world of difference. And then I do kind of love this slide of, how do you go deal with things like depression and anxiety? And it's so simple as get out and go do the things that you enjoy doing, like whatever that is. So I did my fellowship in movement disorders at Medical College of Georgia, which is in Augusta, right? And so much golf in Augusta. Like I'm not a golfer, but cool. Like these folks are, and great, let's go play the back nine. I don't know. And you'd have patients who would come in and get really frustrated because, I played golf my whole life and this was my handicap and now I can't hit that same handicap. Well, that's okay. Go have a nice day of playing golf. Like it's beautiful outside. Like go enjoy the activity. It's okay if you're not hitting the same score that you hit when you were 25, like that type of thing. I own one set of golf clubs. They're rusty. I thought they were graphite, and I was showing them to my buddy like a long time ago. He was like, oh my God, they're graphite clubs. Like, how cool. And then we realized they were just rusty. And that was it. They don't show up very much anymore. But get out, go do the things you enjoy. Get outside of the room. Talk with people about it. And then things like alcohol, well, that's a depressant. And so if you're already depressed, this is a terrible idea. Like, let's get away from the alcohol and like the downers, that sort of stuff. We're talking about what is a psychiatrist and what is a psychologist, because I think they sound so similar, but they have different roles. So let's define what those roles are. So the psychiatrist, so these are going to be the people that classically, they write prescriptions. And there's a lot of medicines for depression, right? And there's a lot of different classes of medicines for depression. So there's a lot of different options there. I think there's this idea maybe of starting new medicines for depression of, well, if I start that citalopram, then I got to take it for the rest of my life. And that's not how this goes. Maybe you take these medicines for depression for 6 months or a year because you're having a really tough time, and then things are doing better, and you know what? Maybe I don't need these medicines, and that's okay. You can stop taking them. So there's different ways to go do about these medicines for things like depression or even anxiety. And then the psychologist, they're not going to treat these things so much with pills, but they can treat you with things like, hey, let's sit and talk about it and learn some coping mechanisms for this. Or what are some really healthy ways to deal with this negative energy that you have when you get this anxiety, right? Because there's some really positive ways to go deal with that sort of those negative intrusive thoughts of having, stress and anxiety and stuff like that. Or some really healthy ways that we can deal with things like depression and how we're going to take out those sort of negative energies too. And don't underestimate people like counselors, whether that be at the church or in the community, or maybe there's the matriarch of the family, or like however that goes. My grandmother, my mother's mom, totally the matriarch of the family. Oh man, like we all just be sitting around at Christmas or whatever, and she's like, let's go talk over here. She's an amazing woman. But that family member or that community member, like go do that. And social workers are like golden. They're incredible. In being able to connect to resources, that is because there's great resources out there with HDSA or other things, but all the resources in the world, if you don't connect with them, aren't going to help you. So being able to connect with those resources becomes a critical component of all this, and things like social workers can be really helpful with this. Okay. Sleep disturbance and falls. If you're not sleeping good, you're miserable. Right? Like, luckily, I don't have to do things like work 36-hour shifts, go to sleep 3 hours, and work another 36-hour shift anymore. But there was a time in my life when I was a resident when you'd go do silly things like that. And, this isn't going to go well. You're going to have a bad, you're going to feel terrible. So it takes a real physical toll on you if you're not getting enough sleep. And with Huntington's, remember that's the red line, so about 20% of patients are going to have problems with sleeping. And there's a lot of different things you can do there to help with sleep in Huntington's disease. I mean, sure, there's things like pills, but there's a lot of non-medication things you can do to help with sleep, like getting into the same sleep routine or keeping bedtime like plus or minus within an hour every night of the week. Like you see this with kind of younger folks, or sometimes not younger folks. I don't know, like during the work week, maybe you got to wake up at 7 a.m. to go to work, and so typically you go to bed at, 11 or something like that. Get a nice full night, great. But then on the weekend, like I stay up until like 3 or 4 a.m., and then like get on that schedule for 2 days, and then that Monday's going to hurt, right? Like, because you're not going to get good sleep Sunday night. So you're trying to keep that bedtime within roughly the same amount of time. On weekdays and weekends can make a big difference. Something that is underrated, caffeine, all right? This is my 4th cup of coffee today. This is my last one. This is all I get. I know my limits. What I think we forget about with caffeine is it's a long half-life drug. So in other words, let's say that if I have 2 cups of coffee at noon, at 8 p.m. tonight, I'll have 1 cup of caffeine still in me. So this is playing a big role. So, and you'll see folks that are like, I drink 6 Diet Cokes a day. Okay. So when you try to go to bed at 11 p.m., you've probably got 3 Diet Cokes worth of caffeine still in you, and caffeine is absolutely a stimulant, and this can create problems with things like insomnia. So hey, look, man, like I'm not taking your morning cup of coffee away from you, but let's knock it off after lunch, something like that. If this becomes a problem, it's probably a good idea. And then getting off balance and falls, which in Huntington's is something you don't necessarily see early on, but you start seeing later on in the disease. And, everybody's a little bit different, but maybe what would be average is, 7, 8, 9 years into this thing, you start getting a little bit off balance. And in so many ways, the falls to ground in Huntington's becomes a really critical thing of what we're trying to do. Because the 2 big things I'm trying to prevent in Huntington's, choking on foods and liquids, because people will get pneumonias, aspiration pneumonias, that's a common way that people die. Or fall to ground, breaking arms or legs, and then I have to have surgery to go fix my leg, and then I'm laying in a hospital bed for like 6 weeks, and then I get blood clots and bladder infections and pneumonias, and that's the classic way that people die, right? So the way you deal with that type of thing is you prevent that from happening in the first place by trying to prevent falls. And there's a lot of different ways you can do that. And like we said earlier, the chorea, all these extra movements can knock you off your balance because you can't correct yourself. So that's going to be something to watch out for too. So yeah, so we're talking about her. In a moment here, she's going to stand up. I know you guys have already seen this one. That's okay. There. And now she's going to get off balance a little bit right there. And then one more here, right? So it can play a role. So, how do we deal with falls? Things like physical therapy, occupational therapy can be really helpful. So things like learning the right techniques to get, out of the chair, off of the toilet, like these sorts of things. There's techniques to be able to do that. And there's also techniques the occupational therapist can train, not just you, the patient, but your spouse, the caregiver, to be able to help and do these things right. I always think of, if you want to go buy a Harley Davidson, I don't know why you would want to do that, but you might want to do that. Then if you go buy a Harley, like they'll train you at the Harley shop. You can be a 90-pound female, and they'll train you how to go pick up a bike. And there's a right technique of how to go do that. If you do it the right way, then it's really not that hard. It's kind of interesting. The other part about falling down that I think is really critical is there's a lot of things you can do inside the home to make it a lot more safer. So like the classics would be like tripping on the rug, right? So, I know it's a really nice rug, but if you trip and fall down and break your arm, maybe it's not worth it. Let's get rid of the rug, or things like handrails going down the hallways, or handrails in the bathroom, something to hold on to in the shower. That's a classic one to fall down in the shower, or the kitchen, because I got to turn over here and the water's boiling over there. That's another classic one. So creating these kind of getting rid of the rug in the kitchen. Oh man, you don't need the rug. It's okay. Or the other thing is kind of watching out in the middle of the night. Like you wake up, you go to the bathroom, but let's clear a path. Like let's get the shoes off the floor so that I don't accidentally trip on the shoes when I'm trying to go to the bathroom and I don't want to turn the lights on. Like these are kind of the classics. And then ambulation devices like four-prong cane, or rolling walker, or wheelchair, or electric wheelchair, these sorts of things can be really helpful. And that's another part that you can get out of things like physical therapy, occupational therapy, where, hey, you guys are the experts in this. You tell me, what does that patient need, or what are they comfortable with? Or maybe it's this particular model of rolling walker that's going to work really well for them. Or what I use them a lot for things like electric wheelchairs, electric scooters. There's all sorts of customization they can do, and I can't tell you the details of it, but I know it's amazing when you see it. So let's use those experts in that. Okay. And then things like communication, speech problems, suicidality, aggression, and irritability. So these are kind of lower on the spectrum there. So communication, speech problems, about 10%, suicidality, about 4%, versus general populations, about 1%. And then irritability, aggression, violence, about the same, about 2% versus about 1% there. Suicidality in Huntington's disease is real, as is depression in Huntington's disease is real. And depression's incredibly common, right? Suicidality is not that rare. And there's a lot of great resources out here. There's the suicidepreventionlifeline.org. Let's talk to somebody right now, 24 hours a day, the 1-800 number. And I know I'm from Mobile, Alabama. Even within Mobile, Alabama, we have like our kind of regional local version of this of, hey, let's talk to somebody right now about what's going on. There's a lot of things that get wrapped up in here, like anger and aggression and irritability and all this types of stuff that are real. And there's very positive ways to go deal with that, and there's very negative ways to go deal with that. So let's deal with it in the positive ways before we get into things like suicidality. And then I pulled this off the HDSA website too, but it's the 5 action steps for helping someone in emotional pain. Let's talk about it. Let's ask them questions. Like let's not just act like this thing doesn't exist. Keep them safe. Be there. Let's stay connected. These are just odds ratios, which is another way to break down the data we were just looking at. Which the only thing that odds ratios means is the farther away you are from the kind of blue spotted line there, the more likely this thing's going to happen. And then if you really want to get into it, if you're not even touching the blue line, then it's statistically significant that this thing's going to happen. So you see dementia there is the one that sticks out the most. Because dementia is going to be, you're going to get, in Huntington's disease, dementia can happen, but it's going to be more of a later onset type of thing. You can get into it at the beginning of movement disorders, but the farther you get along and you're 15 or 20 a year pathway of going down Huntington's disease, then dementia can play more of a problem. And then how do you go deal with that? And that's talking with family members, setting up social structures, ways to go manage this type of thing that could be really helpful. I guess I'm telling stories about my family today for some reason. So I've been a movement neurologist for 10 years. I've been a neurologist now for like 13 years. The most advanced dementia patient I've ever seen was still my grandfather. He had Alzheimer's disease, and he had a long, long time. And then it's okay. What are the different pathways that we can get around this, or be able to make these like activities of daily living thing like happen here? Communication and speech problems, big deal, right? So in some of these things get kind of intertwined, right? That if I have problems communicating with people, or if I'm not communicating with people, then things like stress and anxiety are going to get worse. Things like depression can get worse. And if things like stress, anxiety, and depression are worse, then things like suicidality will get worse. So some of these things are kind of all intertwined. So let's focus on communicating. And that's not just verbal stuff, but that can be written stuff. Keep a journal, a diary, write it out, put it on paper. Like that's what I do when I get really stressed out in life, is I just start writing stuff down. And then, sometimes it's just total crap. And then sometimes it's really great, but you don't know until you write it down. And then the falls, like we've talked probably quite a bit about falls now. But, being able to prevent choking on foods and liquids and falling down and breaking arms and breaking legs is such a huge deal. And then the anger, aggression, irritability, getting short-tempered, easily annoyed, all these types of things. Those are kind of underlying signs of a bigger problem with things like anxiety and depression. It would be kind of the classic diagnosis that you make. But a lot of these things are there too. I'm very much an optimist. I like this one. Pope Benedict, one who has hope lives differently. Like, how great is that? And then the Dalai Lama, never lose hope. Loss of hope is a real cause of failure. So I want to encourage you guys about this stuff, staying positive about these things, and just talking about it. Right? Being able to talk, keep those lines of communication open can make a real difference. Well, thanks a lot. That's what I've got, and I'm going to hand it over. And we'll talk about some of the non-neuropsych problems and comorbidities in Huntington's disease, okay? Hey, thanks, guys. There's a coffee under here somewhere. There it is.
Thank you, Daniel. All right, and then my name is Juebing Huang. I'm a neurologist and practicing University of Mississippi Medical Center and the director of the Huntington's disease. Okay, director of the Huntington's disease Center of Excellence there. And so, Daniel has paved the good road for the comorbidity talk, and then I'm gonna just focus a little bit on things that outside of the brain. So we know that Huntington's disease is a brain disorder, but maybe it also affects some other area of our body. This is the disclosure. And I did receive some research support from different organizations, industry, and including Huntington's Disease Society of America as well. I think I'm gonna skip this, but to emphasize that we all know that Huntington's disease is a brain disease, caused by, a CAG expansions and within the Huntington gene, and it's progressive, and then, cause breakdown of nerve cells. That's what we all know, and that leading to neurologic psychiatric symptoms, involving motor function, cognition mode, and behavior. But we don't pay much attention on the other side. Huntington's is not only a brain disease, and even back in 1993, there's a study has shown that there is very widespread expression of the Huntington's disease gene outside of the brain, both in human being and also in animal models such as rats. And the other side of the slide shows that Huntington's disease, let me see, it does express in different organ systems like thyroid, lung, testes, heart, muscle, fat tissue. Almost everywhere you can see expression of the Huntington's disease gene. Huntington's, we now know a little bit better now that Huntington's disease has effects outside of the brain, cause more like systemic body wasting and the dysfunction of metabolism. Cause a lot. We know metabolism is a big issue. And in some of the mouse models of Huntington's disease, we see that the peripheral component of the pathology of Huntington's disease may also even contribute to the progression of the disease. So it's part of the disease, and it's probably also make the disease progress faster. Let me see. I think I click on the wrong button. Here we go. So this is just to show where can Huntington's disease can affect. We can see that there's, muscle, heart, blood cells, bone, and genital system, and and digestive tract, thyroid. Again, and almost all over the body. I'm gonna spend a couple of minutes just share this study, very interesting study with you guys. This is to study the prevalence of non-psychiatric comorbidities in both symptomatic Huntington's disease and then also pre-symptomatic Huntington's disease population. This study is done in Poland, was published in 2020. What did this study shows that this study it's actually part of the Enroll HD study in Poland, and the study included about 374 patients with symptomatic HD, 95 participants with pre-symptomatic HD. This is the definition of this study for these populations. They say if you have a UHD reading scale less than 5, they consider it's pre-symptomatic. And I also include 74 participants are just the family member that doesn't carry the gene. So the average age of the three groups, you can see that the symptomatic HD patient, they are a lot older, 47.4-year-old, but the pre-symptomatic HD is 34, 31 in men and women, and pretty much similar to the health control group, 35, 33. What's the most interesting part of the study shows that so for example in health control group, and that 0 to 10 is the number of comorbidities. 0 means that the patient, the participant doesn't have any comorbidity, and in the health control, that means that it has nothing to do with HD. 50% of the 74 has no comorbidity at all. That means the other 50% may have one or more comorbidities. So that's kind of the control group. But if you look at the symptomatic HD group, 77% of them has 0 comorbidity. That means the other 93% they have some kind of comorbidity, which is a significant difference compared to 50. And what's more interesting to see here is that even the pre-symptomatic HD group, that means that's the group is pretty much healthy, they have very mild symptoms, they're pretty much normal, independent. Even in this group, only 25% have no comorbidity. That means 75% of this group has some kind of comorbidity. Remember, that's a group, they're pretty much young, 34 years old averagely, compared to health control. They show significantly more comorbidities than the health control group. Furthermore, you can see that this is the chart, they divided, focus on different organ systems. Where are the organ systems affected by Huntington's disease more? And there's a lot of data here. I'm not gonna to touch with everything, but you can see that as expected, psychiatric symptoms, there's 71% of symptomatic HD patients have some kind of psychiatric comorbidity, which is what we expected because that's where HD affects. But even pre-symptomatic HD, 20% compared to only 4% in control group. What's more surprising is that, for example, musculoskeletal system, this is usually in this system is typically it's the muscle disorder, the arthritis, and back pain, neck pain, injury from, fracture or something like that. Even this kind of comorbidity, you see that in control group, 5.4 in symptomatic HD is 31%, and even in pre-symptomatic, HD group, that's 20%. It's significantly higher than, the control group. The other system is the cardiovascular system. You see that, even pre-symptomatic HD patient, 12.6% of those patients have some, cardiovascular disorder compared to only 1.3% in the health control. Of course, symptomatic HD patients are with a higher, comorbidity with involving the cardiovascular system. But you can argue that that's the group, they're older, so maybe they have more. But, if you look into the pre-symptomatic HD patient, they certainly have much more heart comorbidity than the control group. Some other system, with more comorbidities, the gastrointestinal system like the GI system, you see that 60.8% has some GI comorbidity, but it's more so in the symptomatic group, not much in the pre-symptomatic group. Neurological comorbidity, and the number is low, but don't take it wrong because they didn't take consideration of movement disorder. This is neurologic conditions such as seizure, such as stroke, such as carpal tunnel. And so if you excluded the movement disorder, even the other condition, it's higher in the symptomatic HD group, and even in the pre-symptomatic group compared to control. So what does it say? It says that HD does affect a lot other organ system. I mean, it's a whole body disease. It's not just the brain disease. So just touch base a little bit about different organ system. One of the striking observations that heart failure is very common in HD patients. About 30% of patients with HD, and it's the leading cause of death in this patient population, heart failure. There has been multiple epidemiology studies show that heart disease, it is the second most common cause of death in HD. Pathologic change has been observed in HD mouse model as well. And there's a few studies show that cardiac dysfunction can occur even in pre-symptomatic and early HD patients, not just the advanced stage, which we, in the other study we reviewed, and kind of confirm that. And what makes the heart more vulnerable? And it's believed that probably the failure of autonomic function nerve system play a role, but also maybe the mutant Huntington's gene, the expression to the heart tissue, may play a bigger role. And the muscle, skeletal muscle wasting is a kind of like a hallmarker of HD. There's a few interesting studies I'm going to review. One of the case studies reported a semi-professional marathon runner. He was diagnosed with HD later with 43 CAG repeats. He developed signs of slowly progressive muscle disorder. We call myopathy many years before the first sign of Huntington chorea. That means, the muscles was affected even before the brain. There's another study measured, muscle strength of six muscle groups in the lower extremity in 20 people with HD, another 20 control. They found that, HD patient has reduced the muscle strength by 50% on average compared to the control group. And this is some mechanism of speculation about, why, and it's believed that maybe mitochondria is one of the energy producing organ and in the cells. Maybe that's the affected by HD. And we all probably know a little bit about weight loss. It's a very significant part of the HD. We have an actual nutritionist in the room. She probably know better than me. And it's usually unintended weight loss and almost affect every individual with HD. It's progressive. It can start in pre-symptomatic gene carrier, but much worse in the later stage of the disease. One may say that maybe it's because all those involuntary movement, maybe it's because of the appetite is poor, so the intake is not enough. But that's not always true, because even in those individuals with a very high calorie intake, they still lose weight. That means it's probably more intrinsic, such as the hypothesis about increased metabolic rate. That might be the reason for Huntington's individual to lose weight. There's certainly other possible cause of weight loss. Of course, difficult swallowing. Then you don't have enough nutrition intake. Depression symptoms can cause appetite to be low. Some people have GI upsets, disturbance can affect absorption or something like that. There are also other organ systems being affected by HD in research study, including testicular atrophy, bone mass and loss of bone density, and dysfunction of blood cell, liver function abnormality, thyroid function abnormality, all have been reported in HD. I'm gonna just spend a few more minutes talking about that there's some other comorbidities we believe may or may not be associated with HD, but they are very common. For example, respiratory problem, has been observed that reduce the lung function and the muscle strength of the respiratory system, the breathing system, are not only associated with end-stage HD, but occur much earlier. And of course, this can affect a lot of issues, especially, can negatively impact the respiratory function, leaving patients vulnerable to infection, for example, COVID or something, aspiration pneumonia. Swallowing difficulty is something we know very well, because the Huntington's disease can affect the coordination of the muscle, in the mouth and behind the mouth, and then cause swallowing difficulty. What we also know that it can affect the very early stage of the disease, and it can become a major problem in later stage of the disease by inducing choking, and also sometimes occasionally see cardiac arrest because of the choking, episodes. That's the reason, in most of the HD clinic and then regular assessment by speech therapists and about the swallowing function, intervene, training, and early on, it's very essential. Urologic symptoms, this is something very common. It's, it means increased frequency, urine urgency, incontinence, or sometimes, too many bathroom trips at night, called nocturia. This could be multifunctional, it could be secondary to a lot of reasons, but, certainly deterioration of the brain can play a major role. And when we see patients with a urinary system problem, we always tell patients, pay attention to other factors, such as we want to make sure you don't have a UTI to begin with. For men, we want to make sure you don't have a prostate problem, which is a separate issue. For women, a lot of time, pelvic floor disorder can also cause those symptoms. Sometimes we may ask you to check with a specialist first. There's a way to manage those symptoms, but simply lifestyle strategy, behavior change, such as minimize fluid intake before sleep, such as, go to bathroom before you go out, or try to train your bladder by go to the bathroom every 2-3 hours regularly, and don't wait until you really have the urge to go to the bathroom, you cannot make it. So that's kind of like what you can do by yourself, but also, you can talk to your doctor about medications. A lot of times, sometimes we do refer, much more severe cases to urologists, and they can have some more interventional, procedures or something like that. Juuling, it's another very troublesome sometimes, and with HD, and oftentimes it's believed that it's because of the involuntary movement of the tongue and the tissue around, but also has something to do with the difficult swallowing. There's a lot of medications can help with the juuling, but most of the medication, they are in the class we call anticholinergic medication. They have a lot of side effects, as Daniel has mentioned about, confusion, constipation, even urinary retention. That's something you really want to talk to your doctor about, in what medication fits you better. And in severe case, Botox injection has been recommended, injection around this area, and to, into the salivary glands in order to stop the production of the saliva. This is the approach we typically do for Parkinson's patient, but for HD patient, of course, it should help as well. And constipation is very common, especially in older and later stage Huntington's disease patient. And of course, talk to your doctor about medication, but you can do a lot of things to, to manage constipation. For example, increase fiber, increase water intakes, and probiotics, prebiotics can help. And the physical activity, the more you're active, the better your bowel move. And so that's not a secret. And pain is very common in HD due to multiple reasons. It's not just because of Huntington's disease. You have arthritis, you have muscle spasm, and you have pinched nerve. And so you can have different sorts of pain. The management can be different, depends on the specific situation, but physical therapy, massage, acupuncture, medications, and or play a role. And the visual symptoms, it's something, we don't talk a lot, but, we do get a lot of patients with blurry vision, double vision, have problem reading, and at nighttime with the poor eyesight at nighttime. And those can affect the driving. So it's not only the coordination problem can affect the driving, but vision can affect driving as well. So this is something you're gonna have to talk to your eye doctor. And then, but of course, occupational therapy can help coping the vision disturbance while dealing with the Huntington's disease. We sometimes recommend patients to go through a driving evaluation because of the vision, so to say if how safe the individual can drive. One topic we don't talk a lot, but I get a lot of phone call from other doctors say, I have a Huntington's patient and he's going to a procedure or surgery, something like, the surgeon always asks, are you okay for us to do the procedure? Is the patient okay to go through general anesthesia? So something we don't think about, and actually there's a research study done by Mayo Clinic. It's an observation of 11 patients with HD going through different kind of surgery. So the conclusion actually is that a patient with HD have normal response to general anesthesia. That means it's safe to get surgery done. But the anesthesiologists do, they do have to pay attention to medications because HD patients take a lot of psychotropic medication, and which sometimes can interact with the anesthesia medications. That's something they have to keep in mind. Also, a lot of HD patients have swallowing problem, bowel dysfunction, so they need to watch for aspiration pneumonia. So that's something, do you let your doctor talk to the neurologist if you go through a surgery? But I think in general, we think it's safe to go through surgery, just take some precautions. Polypharmacy is very common in HD. We said we try to avoid polypharmacy, but We have medication to treat the chorea, to treat the depression, to treat the insomnia, and then sometimes we have to take all of those medications together. So this medication can cause a lot of side effects, and so try to avoid if possible. But more important, try to let your doctor know if you're taking a new medication, and then make sure they don't have interaction with each other. Of course, the last slides, just to watch out unexpected comorbidities. And we have HD, but that's only one of the problems. We do sometimes get into other circumstances. For example, someone with HD with balance problem, with frequent falls, can injure the neck, can cause spinal cord compression. So you can suddenly being much weaker in your legs, and with your speech problem when other change. In that case, that it's an emergency. HD patient can also have breathing difficulty, but chest pain. In that case, you always have to think about heart attack and then blood clot in lungs. I had a patient recently. He had family history of HD, but he has some symptoms. So they never see doctor to get diagnosis. He was admitted to our hospital. He had a stroke, and affected the same area of HD, and his balance was much worse. His speech was much worse. That's why he ended up in the hospital. And from there, he told doctors that one of his family member has HD. So we were able to confirm his HD diagnosis by that. That means, think about HD patient can have other complications such as stroke as well. So again, take home message a little bit, just that, we need to be aware that HD is not only a brain disease, it can affect the whole body. And always talk to your doctor about any symptoms you're experiencing. And even you are having very mild symptoms, try to establish with a good primary care doctor as early as possible. Try to do the wellness check every year. Try to be proactive. Try to stay active physically, mentally, and socially. Try to prevent other complications come on. It's very important. And that's the way you build resilience, by focus on the feeling, the joy, and the love. I think, be aware and, stay with the doctor and try to see doctors, try to see specialists. And it's something, we have to think about. We have HD, we have something else to take care of as well. Thank you.